You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about peripheral artery disease of the limb. We'll talk about epidemiology, move on to screening, then intermittent claudication, acute limb ischemia, and medications for PAD. Finally, we'll end with a short section on finger PAD. Let's start with the epidemiology. PAD patients with claudication have a 25 to 30% all-cause 5-year mortality and a 20% 5-year cardiovascular mortality. PAD patients are more likely to get MI than to get limb adverse events. An additional 20% of PAD patients will have non-fatal myocardial infarction or non-fatal stroke in the same 5 years of follow-up. Regarding limb events, more than 70% of patients will have stable claudication at 5-year follow-up. 16% will have progressive claudication, 7% will require surgical revascularization, and less than 5% will require amputation. Cigarette smoking and diabetes mellitus confer a much higher risk for PAD than hypercholesterolemia, with relative risk of 4.5, 2.7, and 1.7 respectively. Screening. Officially, the people at increased risk for PAD who need screening with ankle brachial index, or ABI, are all people 65 years of age and older. 50 to 64-year-olds who have risk factors for atherosclerosis, which is defined as diabetes, smoking, hyperlipidemia or hypertension, or a family history of PAD. Less than 50-year-olds who have diabetes plus one other risk factor for atherosclerosis. In addition, you should also screen individuals with known atherosclerotic disease in another vascular bed, such as in a coronary, carotid, subclavian, renal, or mesenteric artery, or abdominal aorta territories. These are the AHA-ACC guidelines. The USPSTF does not endorse asymptomatic ABI screening yet. You are also allowed to order ABI testing in patients who have any signs or symptoms on physical exam or interview that are suggestive of PAD. Symptoms suggestive of PAD are claudication, other non-joint related exertional lower extremity symptoms, impaired walking function, and ischemic rest pain. Physical exam findings suggestive of PAD are abnormal lower extremity pulses, vascular bruit, non-healing lower extremity wound, lower extremity gangrene, and elevation pallor-dependent rubor. So what happens when you actually get an ABI? A normal ABI is 1.0 to 1.4. A borderline ABI is 0.91 to 0.99. An abnormal ABI is 0.90 or less. An ABI that is unexpectedly more than 1.40 means that you have non-compressible arteries that are due to severe calcification, which can be seen in patients with CKD or diabetes, for which you should do a toe brachial index. A normal toe brachial index is more than 0.70. Abnormal is 0.70 or less. If the ABI is normal but the patient has exertional non-joint related leg symptoms, then do exercise ABI. A decrement of 20% or more in ankle brachial index values with exercise is diagnostic of arterial obstruction. A borderline ABI of 0.91 to 0.99 that is symptomatic should also be given exercise ABI. If the ABI turns out to be normal or borderline, but there are non-healing wounds or gangrene, you can still diagnose critical limb ischemia by using transcutaneous oxygen pressure or skin perfusion pressure. In critical limb ischemia, the ABI is usually going to be less than 0.5. On ABI, segmental pressure measurements of the lower extremities are obtained with pneumatic cuffs over the upper and lower thigh, calf, ankle, and above the metatarsal area of the foot. Then systolic pressures are measured using a Doppler probe. A pressure gradient of greater than 20 millimeters of mercury between successive segments in the lower extremities, or greater than 10 millimeters of mercury between successive segments in the upper extremities, is considered significant peripheral stenosis. In the iliac and femoral arteries, a 70 to 90% decrease in the cross-sectional area of the artery must be present to create a pressure gradient. Since PAD patients often have subclavian stenosis, which causes a difference in arm blood pressures, you should take the higher of the two arm blood pressures and use that systolic blood pressure for calculating the ABI. Arterial stenosis is suspected on ultrasound of an extremity when atheroma and stenosis are visualized and confirmed by spectral Doppler with a significant increase in velocities, as well as color Doppler, which shows flow acceleration. Contrast angiography is the invasive gold standard for identifying peripheral arterial stenoses. Advances in the resolution of gadolinium-enhanced MRI angiography have made it as good as conventional contrast-enhanced digital subtraction angiography in looking for stenoses in the aorta, iliac, femoral popliteal, and tibial peroneal arteries. Now we'll move on to intermittent claudication. Intermittent claudication due to PAD is characterized by leg pain or fatigue during exercise that resolves with rest. In contrast, neurogenic pseudoclaudication due to spinal stenosis is characterized not just by walking pain, but also pain on standing. The lack of symptoms is not a reliable way to exclude the presence of PAD. For PAD that has claudication, in addition to taking aspirin and cilostazol, you must make the patient do supervised exercise therapy for 30 minutes 3 times a week for 12 weeks before you discuss sending them to vascular surgery or getting MR angiography or CT angiography. Meta-analyses have shown that supervised exercise therapy in patients with intermittent claudication increases maximum walking distances by 50% to 200%. Supervised exercise is beneficial in patients with symptomatic claudication, but it is not useful in the management of patients with CLI. Now let's talk about acute limb ischemia. The 6 P's of limb ischemia are pain, pallor, paralysis, pulse deficit, paresthesia, and poikilothermia. The temperature change seen in acute limb ischemia is poikilothermia, assumption of ambient temperature, not hypothermia. Pachydermia, which is thick skin, and purple discoloration are associated with venous outflow obstruction or lymphatic drainage limitations, not acute limb ischemia. The alteration in sensation in critical limb ischemia is paresthesias, pins and needles sensation, not numbness. Chronic limb ischemia is defined as chronic, more than 2 weeks, ischemic rest pain, non-healing wound or ulcers, or gangrene in one or both legs attributable to proven arterial occlusive disease. Acute limb ischemia should have less than 2 weeks of the 6 Ps in contrast. There are 4 categories of viability when you encounter an acutely cold, painful leg concerning for acute limb ischemia. Using Doppler, you can hear audible arterial pulses and audible venous pulses. In that situation, that is category 1. 10% is a viable limb. There should be normal motor function, no sensory loss, and intact capillary refill. For viable limbs, which are category 1, they make up 10% of acute limb ischemia, please revascularize urgently within 6 to 24 hours and anticoagulate unless contraindicated. Now, in 45% of cases, you will hear inaudible arterial pulses, but audible venous pulses. So the arterial pulses go before the venous pulses disappear. In this situation, you need to look at a motor function. If the motor function is intact, that's category 2A, a marginally threatened limb. Whereas if the motor function is impaired, that's category 2B, an immediately threatened limb. The marginally threatened limb, which is category 2A when that has motor function intact, you will have slow to intact capillary refill, sensory loss limited to toes if present, and no muscle weakness. This is salvageable if treated promptly. You need to revascularize emergently within 6 hours and anticoagulate unless contraindicated. In this situation, where the limb is marginally threatened, class 2A with motor function intact, it is okay to get a CT or lower extremity angiography to visualize what to revascularize. This is in contrast with type 2B, the immediately threatened limb, where you do not have time for that. The CT angiography of the lower extremity should include imaging of the aorta, iliacs, femorals, popliteals, and runoff of the distal vessels. Now, going to that category 2B we mentioned, if motor function is impaired, that means that this is category B, an immediately threatened acute limb. You will have slow to absent capillary refill, sensory loss more than toes, rest pain, mild or moderate muscle weakness. This is still salvageable if treated emergently. You need to revascularize immediately threatened limbs within 6 hours. That again, if motor function impaired, that's category 2B, you need to revascularize this within 6 hours and anticoagulate unless contraindicated. In this situation of immediately threatened limb, category 2B, you cannot wait for the CT or lower extremity angiography to happen. You need to take the patient straight to the OR. Then you have the situation of inaudible arterial pulses and inaudible venous pulses. This makes up category 3, which is 45%. This is irreversible. You will have complete loss of motor function, complete sensory loss, and absent capillary refill. There's no point to revascularizing this. Do primary amputation. If marginally threatened or immediately threatened limbs are not revascularized within 6 hours, the prolonged ischemia may end up requiring amputation, as I mentioned. If CLI has Doppler pulses, it is by definition having potential viability, so you should not amputate it. Revascularization is the way to go. Again, if there's Doppler pulses, you want to revascularize it and not just amputate it. Should you do revascularization for acute limb ischemia by the endovascular approach or surgical approach? Endovascular is better if the symptoms are less than 2 weeks, whereas surgical is better if the symptoms are more than 2 weeks. Percutaneous transluminal angioplasty of the iliac artery results in patency rates of 70% at 4 years, with higher patency rates as stents are delivered. Aortobifemoral bypass surgery results in 10-year patency rates of 90%. Now we'll talk about PAD medications, starting with antiplatelets. Recommendations regarding antiplatelets have shifted considerably over the years. Let's hear from the most recent guidelines. The 2024 AHA-ACC SVM guideline for the management of lower extremity peripheral artery disease says, in patients with symptomatic PAD, low-dose rivaroxaban at 2.5 twice daily, combined with low-dose aspirin, class 1, or a single antiplatelet therapy with clopidogrel alone, or single antiplatelet therapy with aspirin alone, all of these are class 1, it is effective to reduce the risk of MACE and MALI. In patients with symptomatic PAD without recent revascularization, the benefit of dual antiplatelet therapy is uncertain. That's a class 2B. In patients with PAD without another indication, such as atrial fibrillation, full dose intensity oral anticoagulation should not be used to try and reduce the risk of MACE and MALI. That's class 3 harm. In other words, you don't do DAP for the full anticoagulation for PAD itself. You either choose aspirin or P2Y12 inhibitor because of the risk of bleeding, or aspirin plus low-dose rivaroxaban. Unless they have had PAD that has been intervened upon with an endovascular stent or surgical lower extremity bypass, then you can do DAP, which we'll talk about next. What do guidelines say about PAD patients who have undergone revascularization? After endovascular or surgical revascularization for PAD, low-dose rivaroxaban, 2.5 milligrams twice daily, combined with low-dose aspirin is recommended to reduce the risk of MACE and MALI. That's class 1. After endovascular revascularization for PAD, dual antiplatelet therapy with an P2Y12 inhibitor and a low-dose aspirin is reasonable for at least 1 to 6 months. That's class 2A. After endovascular or surgical revascularization in patients with PAD who require full intensity anticoagulation for another indication and are not at high risk for bleeding, adding a single antiplatelet therapy on top of that full intensity anticoagulation is reasonable. That's a class 2A recommendation. In other words, the guidelines prefer you to use low-dose rivaroxaban plus aspirin after endovascular or surgical PAD revascularization with a class 1 indication. But for endovascular PAD revascularization, you are allowed to use a P2Y12 inhibitor and aspirin instead of rivaroxaban and aspirin with a class 2A indication. And if you have to be on a full anticoagulant already for some other indication such as PE or AFib, then you can do single antiplatelet plus the full anticoagulant. but it doesn't specify whether the single antiplatelet you can add to the full anticoagulant regimen should be aspirin or a P2Y12 inhibitor. Ticagrelor can be added to aspirin only in symptomatic PAD patients who have had prior MI, according to Pegasus-TIMI. This was a randomized controlled trial that compared placebo on a background of aspirin in the TIMI studies. If a symptomatic patient has not had prior MI, then you should not bother adding ticagrelor onto aspirin. Now, lipid lowering. What do the 2024 PAD guidelines say about lipid lowering in patients with PAD? In patients with PAD, treatment with high-intensity statin therapy is indicated with an aim of achieving at least 50% reduced low-density lipoprotein cholesterol. That is class 1, so it's highly recommended. In patients with PAD who are on maximally tolerated statin therapy and have an LDL cholesterol level of 70 or more, it is reasonable to add PCSK9 inhibitor therapy. In patients with PAD who are on maximally tolerated statin therapy and have an LDL-C cholesterol level of at least 70 mg per dil, it is reasonable to add ezetimibe therapy, class 2A, for further lipid lowering. In other words, in patients with isolated PAD and no other indication for lipid lowering, the goal is to lower LDL until 70 mg per dil with a statin and add on ezetimibe or PCSK9 inhibitor if needed. Evolocimab reduces MACE in PAD, so it can further be given. Now we'll talk about symptomatic relief. Cilostazol is a phosphodiesterase 3 inhibitor. By inhibiting PDE3, cilostazol induces intracellular levels of cyclic AMP in vascular smooth muscle cells and platelets, leading to vasodilation of the peripheral arteries and inhibition of the platelet aggregation, respectively, decreasing thrombus formation. Although cilostazol does not change the rate of MACE or MALI, cilostazol improves walking distance and provides symptom relief in patients who have intermittent claudication. The 2024 PAD guidelines say, in patients with claudication, cilostazol is recommended to improve leg symptoms and increase walking distance. That's a class 1 recommendation. You are not allowed to prescribe cilostazol in a PAD patient if they have not had claudication. Cilostazol is contraindicated in heart failure due to increased mortality seen in studies of other PDE5 inhibitors. The 2024 PAD guidelines say in patients with PAD and congestive heart failure of any severity, cilostazol should not be administered. It's class 3 harm. The dose of cilostazol is 100 milligrams BID. It does not have a role in acute critical limb ischemia. Pentoxifylline, which is used to improve symptoms in symptomatic PAD, increases the deformability of red blood cells, reduces blood viscosity, and decreases fibrinogen concentration and reduces platelets adhesiveness. Pentoxifylline is no longer recommended in the PAD guidelines. The 2024 PAD guidelines say in patients with chronic symptomatic PAD, pentoxifylline is not recommended for treatment of claudication. That's class 3 benefit. Now we'll quickly touch upon finger PAD. Raynaud phenomenon can be triggered by drugs that enhance vasoconstriction, including beta blockers, clonidine, ergot alkaloids, and dopaminergic alkaloids such as bromocriptine, sympathomimetic stimulants, and cyclosporin. Raynaud phenomenon can also be triggered by drugs that cause endothelial dysfunction, including chemotherapy agents such as cisplatin and bleomycin. Surprisingly, Raynaud phenomenon is not triggered by cigarette smoking, heroin use, or alcohol use. Primary Raynaud's phenomenon can occur in 5 to 10% of the general population. Primary Raynaud's phenomenon usually occurs in healthy women less than 30 years of age without signs of tissue injury or lab abnormalities. Secondary Raynaud's phenomenon usually occurs in men more than 50 years of age and has signs of tissue ischemia or ulceration, lab abnormalities, and systemic symptoms. Thumb involvement is more common in secondary Raynaud phenomenon. Now, how about nail fold capillary examination? Nail fold capillary examination is an important part of the PAD physical exam and can differentiate between primary and secondary Raynaud phenomenon when it comes to the fingers. Nail fold capillary examination involves placing oil on the nail fold or cuticle and observing the capillaries with an ophthalmoscope. Normal capillaries are fine loops suggesting primary Raynaud phenomenon, which is too low risk for subsequent development of connective tissue disease. On the other hand, abnormal capillaries are enlarged with disorganized architecture and microhemorrhages. This suggests secondary Raynaud phenomenon, so you should evaluate for an underlying disorder. Treatment for both primary and secondary Raynaud is nifedipine or diltiazem. That's a DHP and a non-DHP respectively. If the Raynaud phenomenon is refractory to nifedipine or diltiazem, then check ANA, RF, CBC, BMP, and complement to look for causes of Raynaud disease secondary to connective tissue disease and vascular lesions. You can add aspirin to a calcium channel blocker for patients at risk of digital ulceration. That's all for peripheral artery disease of the limb. We talked about epidemiology, screening, intermittent claudication, acute limb ischemia, and medications for limb ischemia.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.